Hello, future public health emergency preparedness professionals. Today we're going to dive deeper into the COVID-19 pandemic in Canada. We need to reflect on the lessons learned, observed, and lost to ensure improvements in emergency preparedness. Here are the presentation's objectives. 1. To distinguish between the 3 lessons during the COVID-19 pandemic in Canada. 2. To understand the impact of previous public health strategies. And 3. To recognize gaps still present regarding pandemic emergency preparedness. Before getting any further, let's define the 3 lessons. Lessons learned are problems that are identified and changes are made to processes and systems to address them. Lessons observed are problems that are documented but not yet acted on in a meaningful way and repeat themselves disaster after disaster. Lessons lost are problems that are ignored and thus repeat themselves in the future. I would like to start by painting a picture for you of the COVID-19 pandemic in Canada. The first case was reported on January 25, 2020. Approximately 1.4 million people contracted COVID-19 in Canada, and social determinants of health such as education and employment increased a person's risk of contracting this virus. A lesson learned was the power of social media. This is because it was only identified during COVID-19 and did not exist during previous pandemics. During the SARS and H1N1 pandemics, people sought out information and guidance from either the government, newspapers, or television. However, COVID-19 emerged in a post-television era, so Canadians gathered their guidance from social media. Those without medical, scientific, or public health expertise struggled to distinguish between accurate and misleading information. This led to the spread of misinformation, such as that the virus was produced in a lab. Thankfully, there have been efforts to address this issue, including increased funding through the Digital Citizen Contribution for organizations focused on improving digital literacy. A lesson observed was burnout among healthcare professionals. This is because it was identified during previous pandemics and the solutions implemented were ineffective. According to one study, healthcare professionals in Toronto during the SARS outbreak experienced significantly higher levels of burnout. A solution was an educational program that focused on showcasing a normal stress response, effective coping strategies, and the power of organizational resilience. The solution did temporarily improve burnout, but there was no data collected to showcase whether it was effective during future pandemics. It was likely not effective given the high rates of burnout during the COVID-19 pandemic in Canada. According to a study by Leo et al., 89.5% of nurses and 75.6% of physicians experienced extreme burnout during COVID. The highest percentage of burnout was observed among women and those belonging to ethnic minorities. These show that this issue has persisted through time and is likely to occur again. Contributing factors to this burnout were staff shortages and long work hours. A lesson lost was limited data collection from racialized groups. This is because it occurred previously during the H1N1 pandemic in Canada, but the issue was ignored. More specifically, according to Moghadas et al., during the H1N1 pandemic, there was a deficiency in collecting demographic and epidemiological data. No measures were taken to improve data collection, even though it was recommended to establish national data collection standards. This ultimately led to the same mistakes being repeated during the COVID-19 pandemic. According to Anand et al., in Canada during COVID-19, there was insufficient data collection regarding infectivity rates among various racialized groups. Consequently, the government found it challenging to pinpoint the hotspots present and optimize testing and vaccination opportunities, negatively impacting the health of racialized groups. Thank you for listening to my presentation.